Welcome to Voices in Nursing with Dr. Nozil, Care, Policy, and Leadership. I am your host, Dr. Yolaine Nozil. Today, we're going to show panel discussions at the Georgia Association of Nurse Educators, and that this podcast is sponsored by GA Healthcare Training and Consulting.
Good afternoon, everyone. Fantastic. I am so glad that you all have decided to come and join us for a very rousing, wonderful, and dynamic presentation. My name is Dr. Michelle Nelson, and I am your advocacy queen. I am all things advocacy, health policy, legislation, but most importantly, I am a proud nurse and the proud director of graduate programs at the mighty Clayton State University.
And my name is Dr.Yolaine Hooks. I get the pleasure of being the Dean for the College of Health at Clayton State University. I've been at Clayton State for 3 years. I'm serving in the Dean role for the College of Health and also the interim Dean role for the College of Arts and Sciences because I didn't feel like I had enough to do. I'm not sure I could say that I'm your advocacy king, but we'll go with that. And so we'll talk a little bit about, obviously, advocacy, policy, lobbying, and those kind of concepts as we go through. And Dr. Nelson will let you know, after we have Dr. Collins' introduction, a little bit about how we're going to structure this presentation, which is going to be different than probably just a podium style. It'll be more of a fireside chat, but she'll go into more detail about that.
Thank you, Dr. Hooks. And I am Elisha Collins. I serve as the Assistant Dean of the School of Nursing at Clayton State University. I do believe that it's an honor to teach nursing students today, both at undergraduate and graduate. And I've been at Clayton State University for 16 years.
All right. So as Dr. Hooks did say, this presentation is going to be a little different. We are doing what you would call a fireside chat or panel where we're going to be here talking about advocacy related issues and how you can integrate them into your curricula. But we're going to be doing it as a conversation amongst friends, and you're part of the conversation, right? So if we are talking about something and you'd like to chime in. We will be taking questions at the end as well. But it is very important that you are a part of this discussion. So we don't want to be talking to you or at you. This is a with you situation. Now, these are, first and foremost, let me say that we have absolutely no conflicts or disclosures to present. We then have some objectives, as you can see them on the screen, and you can read them, right? But as far as I'm concerned, if we've done our job correctly, you will leave here renewed, refreshed, reinvigorated, and ready to engage in advocacy-related issues. We want to meet you where you are and to make sure that you feel empowered to be able to move to the next level of your advocacy journey and beyond. Okay? So, next slide. I'm going to start with the very first question. And that question is going to first go to Dr. Collins. Dr. Collins, I would like for you to share with us and enlighten the audience and give an overview of your advocacy journey. What got you engaged in this?
Thank you, Dr. Nelson. So my advocacy journey began as a bedside nurse, as I'm sure most nurses' advocacy did begin. So I was advocating for patients, patient safety. It progressed as I joined organizations. That was a big part of my undergraduate career, is to join organizations. So I joined GNA and ANA right away, and I've been a member for over 22 years. It expanded as I began to teach the health policy course in the graduate program with Dr. Nelson. And that allowed me to see how nurses and lobbyists work on behalf of nursing as a whole with policymakers to expand legislation for healthcare professionals.
Thank you so very much, Dr. Collins. And what about you, Dr. Hunks? How did your advocacy journey begin?
Yeah, and Dr. Collins mentioned this. But how many of you have been an advocate as a part of your role, your life? Right. So everybody should be raising their hand. When we started thinking about advocacy, that really aligns very well with the nursing profession. So if you go back and look at what the Latin word means that was derived to create the word advocacy, the derivation means one called to aid. That's all what we do. When you look at the levels of advocacy, there's individual advocacy, there's self-advocacy, and there's systems level advocacy. And so each of us as nurses are doing at least individual advocacy because we're advocating for ourselves. We've asked for different schedules. We've asked for different pay and compensation. We've also asked for ways in which we can better care for our patients through a lot of various communication channels. And then looking at systems level change around policies and legislation. Oftentimes, people confuse policy advocacy work with lobbying or lobbyist. And so all lobbying is advocacy, but not all advocacy is lobbying. So we have to understand the differences between those concepts. So as my journey in advocacy began 35 years ago as a professional, when I graduated from Augusta University with my Bachelor's of Science in Nursing, I found that I was called to advocate on behalf of, as a neonatal intensive care unit nurse at the Medical College of Georgia, on behalf of patients that obviously could not speak for themselves. And so I learned quite a bit in that role as a NICU nurse. I knew very quickly into my career that I wanted to be in a leadership role. And so I moved to the very other end of the spectrum to be a director of nursing for a skilled nursing facility. Colleagues, friends, family were, what are you thinking? And so what I learned is that the strategies that I learned of being a NICU nurse, advocating for those individuals who could not speak for themselves, was very relevant and transferable as a director of nursing with very limited resources. If you all have been in a skilled nursing facility, either having a patient, a family member, or being a nurse in one of those spaces, you know that resources there are very different. So that has been my professional advocacy before joining the academic space. And during that transition, after often advocating for policy change to make the work environment better for nurses and other healthcare professionals, but primarily nurses. I was a chief nurse for one of the WellStar hospitals, the Windy Hill location. It's a long-term acute care hospital, was there for 5 years. A lot of advocacy there on behalf of the care team and the patients who also could not speak for themselves in most cases. It's a long-term ventilator facility for the most part. I then moved to be the chief clinical officer for 3 hospitals in North Carolina. Again, a lot of advocacy work in that particular role. And then completed my PhD and moved into the academic space. Those skills as a chief nurse are also very transferable to what I've been doing as before being a dean, the executive associate dean at Augusta University for 5 years. But that advocacy is what we do, either self-advocacy, individual advocacy on behalf of ourselves or patients, or systems level advocacy.
We're going to have to talk about the Greek when we're done. I have a different journey. I'm from Brooklyn, New York, and I became an advanced practice nurse in New York. I started with an associate's degree, I got a bachelor's degree, I got a master's. And of course, like most nurses, I advocated on behalf of my patients in med-surg and in critical care setting. And I moved to Georgia and I did my PhD at Emory. I remember that policy and advocacy discussed in my undergraduate and graduate programs, but I can't remember. So that's telling you what little of an impact it had on me in the academic space. At that time, when I had just finished Emory and went to Georgia State, and there was a faculty member that was teaching with me, and he said to me, I need you to find a secretary for my organization. And I said, I think I know quite a few people. I can find your secretary. He said, no, we need you. I said, me? I would be the worst secretary ever. If you're looking for minutes, you can forget those because you're not getting no minutes. He says, oh, no, no, no. We need your energy. We just really want to have your energy to come join our organization. I joined the organization and a mess. Oh, they were fighting and carrying on. I used to come to the meetings with my glass of wine and popcorn and watch and go. Whoa, this is fun. Then all of a sudden, there was a vacancy as president. And the vice president becomes president, right? And I said, hold on a second. So I go from advocating for my patients. This is now advocating for myself. Okay, so I've been here longer than her. I've been drinking the wine, eating the popcorn, and trying to fix the problems and all of this. I think I should be president. So I said to her, you feel a lot going on. Aren't you trying to get like your third or fourth doctorate program? What does your husband have to say about this? Oh, so underhanded, right? She comes back the next day and she says to me, my husband says that he doesn't think I should do that. Oh, I'm sorry. Ding, 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 ding. Who's next after the vice president to become president? The secretary. Of course, I knew nothing. If you thought I was a terrible secretary, oh, even worse, was I going to be a president? I wasn't the president of anything before. But we had a very savvy lobbyist who said to me, look, you're now the president. You have to go up to the Capitol because policy is one of the things that is the hallmark of this organization. So I need you to come to the Capitol and you're going to meet your representative and you're going to meet your senator and this one and that one. So I said, oh, okay. I came down and I was so scared, knees knocking. I didn't know what to say. The shyness was all over me. I didn't know what was going on. She said, you need to get past that because these people need to hear from you. So I met with my senator first, Senator John Albers. He's still my senator today. And I started to explain myself. My name is Dr. Michelle Nelson. I'm the president of UAPRN and I blah, 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 blah. And he gave me maybe about 30 seconds before he stopped me. And he said, Dr. Nelson, let me stop you right there and let you know why you'll never get what you're seeking. Okay, why? He said, first of all, nurses don't work together. All you guys do is fight each other. You don't have consistent messaging. You don't come with one voice. You come fragmented. And it is very easy to divide you. This is why physicians do such a much better job because they come with their dollars and they have consistent messaging and speak with one voice. You don't see them come to the Capitol as the cardiologists, the pediatricians, the oncologists. They come as doctors, one voice. It was like he had slapped me across my face. Now, me being from New York, don't ever tell a New Yorker that they can't do something. We're about to fight, carry on, and do all kinds of things. And I went back and I put a plan together on how to bring advanced practice nurses of Georgia together. And I'm not going to tell you more now. We're going to infuse a lot of what we did and what we are currently doing as a group throughout this presentation. But it's when people tell you that you can't do something, you won't, keywords for me, can't, won't, don't, no, say anything like that to me is when I go into hyperdrive. And that's how my advocacy journey started very late in the game, but very intentional and determined. Okay. So I'd like to move on to the next section where I'm going to be handing it over to Dr. Collins for our next question.
Thank you, Drs. Hooks and Nelson, for sharing your advocacy journeys. My second question, and I'll begin with Dr. Hooks, is how must nursing education redefine advocacy to prepare graduates for resource, workforce, and policy influence, not just patient level advocacy? Dr. Hooks.
And so to that point, we're going to talk about a framework that we've developed that we believe needs to be infused into the educational space. So there's a QR code here. We'd really like your feedback. We've shared this at a couple of other meetings. You can do that in real time as far as providing the feedback. However, this QR code will be part of the presentation that's available through the app. So you're able to go back and get feedback later. If that is something that you would like to do, we would appreciate that feedback. We've used the model. It was originally created to advocate for really financial aspects. And we'll show you that in just a second. And because of the work that we were doing around advocacy, I mentioned what I was doing around kind of career and professional advocacy, but I've also been very engaged in the prescriptive authority practices. I am an advanced practice nurse as well. And the other issues that we have faced. Georgia was the last to get prescriptive authority. We know that story. And I think part of that was because of the whole one voice issue. And so I became engaged as I became a nurse practitioner in 2002 around this prescriptive authority. We also had at Augusta University Nursing Associates. Our faculty at that point were able to go into practice. And so we had to advocate on their behalf, work them through the composite medical board process of getting their agreements signed and processed. And if you're an advanced practice nurse, you know that can sometimes be challenging. And so if we all move to the next slide, we created even the next one, the 7-step framework. This was originally developed because at Clayton State University, when I arrived, Clayton State had just out of the most significant decline in student enrollment in the entire institutions within the University System of Georgia. It was post-pandemic. It was in the 21-22 academic year. We saw a 14.1% decline in enrollment. As you can imagine, everyone's hair was on fire. We needed resources. I needed resources for the College of Health. The College of Health has 5 distinct units, the School of Nursing being one of them. And so when we began thinking about how are we going to make sure that those decision makers knew what we needed in order to provide the level of education that we needed to come up with these steps, which actually was retrospective. We had done the work, put things together. We had asked for things. The request that we were advocating for, the finance team really have no idea. And so if you've been in a position as a faculty member and you're asking for resources that you need for your class, or a leadership position, you're asking for equipment that you need for your sim lab, those requests go to, in our case, and in all my academic experiences, to a committee. Oftentimes that committee is representative of many parts of the organization, but not always a nursing voice at that table. So if you ask for a full body, high fidelity simulator HF 211-18 for $48,000, you get this reaction. And so it's really, when we thought about it, number one, we needed to know what was it that we did need to advocate for. So there's a lot of ways to figure that out. There's inputs. And so the first part of the framework is we were asking faculty, staff, students, community of interest members, anyone that would talk to us, what was the industry standard? The simulation center that we have at Clayton State, which we're going to major renovations, did not have some of the aspects that other simulation centers had that we wanted. So we were looking at industry standard, what was already on the list of things that we needed to advocate for. And that was what we called the inputs. So from there, as a group, we said, what are the things that we need? We need more faculty. We need higher compensation for faculty, including our full-time and part-time. We need multiple supplies. There's services we need to make sure our students have access to real resources to help with their learning trajectory. So we determined what was our resource that we were going to request of this committee. So we submitted 7 requests that were significant. All 7 of those were funded. We were the only college to have 100% of our requests funded. And we've had that experience since we started asking using this framework. Yes. So we came up with what is the resource. And then we moved to what's the rationale? Is this something that we must have, or is this good to have? And we were very clear that these are the things that are mandatory for us to be on par with other nursing programs, to meet standards. We wanted to make sure that we were able to have, these are must-haves. Then there are some things, as we're going through this new building renovation, and we're kind of advocating for things that they would be good to have, but we could still continue operations without them being present. So we provide the rationale. Then we moved into what are the implications, the financial implications. If we do this, this is what it's going to cost, and explaining what those are and how we're going to then come up with the return on that investment. Does it mean increasing student retention? That leads to transitions to tuition dollars. If you are in the University System of Georgia in a public situation, you know that a portion of your tuition revenue is only a portion of your budget. The other is state appropriations. And so your enrollment drives what you're going to get 2 years later. And so what's that return on investment? If we can recruit more students and then we can also retain those students, that leads to the return on investment. The other step in this is expanding the lens. What I mean by that is just what I mentioned. We had to make our request visible to the individual that was hearing the request. We knew exactly what we needed. However, those that are making decisions oftentimes don't really understand what that full body high fidelity simulator really means. And so we expanded our lens and we expanded their lens in understanding what the request was. Then that moves to, is the resource what you're advocating for going to get approved or not? If it does, you celebrate, you tell everybody, communicate with all the stakeholders. If it doesn't, then we put it back into what we call our perpetual list. Just because that simulator did not get approved for the first time, we keep that on the list. So this was really kind of the flow, and we call it the resource advocacy framework. And so this is what we're really wanting your feedback on. We've modified this to also now call it the resource advocacy framework for health policy. So the steps are very similar, but they've been amended to reflect what really are the steps you should be taking for advocacy work that's more policy or legislative related. So if you'll go to the next one. So I mentioned the simulation funding and the success that we had with those advocacy requests. So we've taken that original that was meant to advocate for primarily financial resources. You can also use that for non-financial requests. But the other is we've now moved it to being more specific to health policy. So you'll see that there's still the same shape of the clouds and how you move through the steps. The inputs obviously change in terms of who you're going to be asking. These are not comprehensive lists. These are ideas. So these are meant just to really give you kind of an idea starter about who might be an input, but this is certainly not comprehensive. So in this case, it could be you're looking at health outcomes. You could be looking at patient satisfaction feedback, those kinds of things. We know that maternal morbidity and mortality is an issue. So what do we need to do as professional nurses to advocate for policy to address that? So your inputs are going to look very different than the other inputs. But then you decide, okay, what is the initiative that we are going to focus on? So I mentioned, obviously, there was the whole thing from an advanced practice standpoint around prescriptive authority. Now we're trying to be able to order diabetic shoes, and we're trying to order home health, and we're trying to make sure that if we're a psychiatric mental health nurse practitioner, that we can order stimulants for our patients, right? We're trying to make sure we can sign death certificates. There's lots of things that we're working on that you may be interested in. I think one thing that as educators we need to do is we also need to add to that voice. What do we need as nurse educators? Yes, we're nurses, but nursing education has different competencies, as we all know. So from an advocacy standpoint and legislatively, what do we need to improve our situation? You would select your initiative, go through the rationale, what's the supporting evidence of your recommendation or what you're requesting or you're wanting to advocate for. Again, you've got to expand the lens. So just like one of the previous legislators that was mentioned, we needed to make sure now that we expand our own lens. So that learning that Dr. Nelson had regarding one voice led to a whole lot of other things I'm sure she can touch on about how we need to unify and what has already been done to start that unification process about our voice. We don't all have to agree on a particular item that we're advocating for, but we should be supporting it from a nursing perspective, whatever that item might be. So it's expanding our own professional lens because, again, some of our other healthcare professionals, physicians and pharmacists, do this in many cases better than what we do as nurses. So expanding our lens and their lens, what are the implications if we try this policy, like providing advanced practice nurses the ability to write prescription stimulants. What's the implications for that? What are your concerns if you don't, from a legislative standpoint? So a lot of what we do in advocacy is educate. And based on your position, sometimes you're not able to advocate in the name of your employer. And so you're doing that from an individual perspective if you're a state employee, for example. So it's what are the implications and the impact of that? What if this what you're advocating for is successful? What then could that lead to in terms of impact? From that, you implement that change. We know that's important because if you are aware, as advanced practice nurses, for example, we now have a separate license. It used to be that we were authorized to practice. Now we have a separate license. Well, when that passed, that was delayed. The reason it was delayed is because the implementation steps weren't always thought about in advance. So we really have to think about, and we have to help legislators understand if this particular policy rule gets changed, what does this mean? What's the downstream impact? So that was an example. Signing death certificates. There was a whole lot of training that had to be put together before that could be fully implemented. So we are now learning quite a bit about this. And so there's more work that needs to be done around specifically implementation. So then you get, yes, we all celebrate if we get a win like prescriptive authority, we tell everybody. If not, we go right back. We keep it on our list because those are things that year after year. Same thing with the home health bill. If you haven't heard about that, that's something that we thought this year was going to sail right on through because there had been a lot of discussion and agreement previous legislative session. So we really want you to please, as you're thinking about this, whether it be now kind of in real time or after the presentation, this survey, Qualtrics survey, is up on the QR code. There's also the link you can click if you prefer clicking the link to get you to the Qualtrics survey about feedback, because our goal is to continue to modify this because these are the things we want to take back and infuse into the curricula about legislation, policy, advocacy work. So with that being said, I'm going to turn it over to Dr. Nelson.
So some things I wanted to add to what you said. I don't think that we said this earlier. We have actually mapped some of the essentials from AAC and onto the slide so you can see where they fit into your curricula. We're speaking to you about how to advocate for resources, but please understand, this is something that we also want you to be teaching your students. They are advocates in training. We meet them where they are. They come to us at various levels, but these are going to be the future leaders, administrators, who is Dr. Hook's 10.0, 12.0. These are individuals who are now going to be tasked with advocating for resources for their programs. And so becoming an advocate shouldn't happen like I became an advocate, where you fall into advocacy by happenstance. We need to be very intentional and committed to making sure that we're training our students to be advocates that know how to secure the resources needed for themselves as administrators, academicians, researchers, but then also how are they sharing this information with the students that they are tasked to train. So what I wanted to add here is this phase here when you're trying to implement or you're trying to expand the lens, your bill doesn't get passed. You go back to trying to share a rationale with the legislators, particularly with healthcare policy and advocacy. This is a marathon, not a sprint. On the federal level, one of the organizations that I belong to, I'm on the board for AANP as a Regional 11 director. We have been talking about the need for advanced practice nurses to write orders for diabetic shoes. A shoe. I think I went to a conference when I was at Emory. We're going back nearly 20 years We have been lobbying to be able to write for diabetic shoes. Now, you would think that that is so basic. We're the ones, especially in rural areas, that see these patients. The patients know us as their primary care providers. They've never seen the doctor who is now tasked with writing that order for them. And what happens in many instances is care is delayed. Not only is care delayed, but we have increase in costs. When the patient has to see you, then they have to go see the physician to write the order. Something as small as a callus can turn into an amputated toe, foot, leg. Who does that serve? And so every single year, we go back to DC and we fight like the Dickens, and we're going to show up every year until the right mix of legislators is in power and we can impress upon them why it is so important. Okay? This is going to be all of us. There's no person in this room or in this country that does not interface with nurses. And so we have to find a way to be able to advocate with one voice for the things that are going to do the greatest good for the greatest amount of people in the greatest ways. So this is a resource, very succinct, very understandable. You're probably already doing this. It might not be in this order, but we're presenting this to you in hopes that we will all be able to use something like this and share with our students, train our students, because how many nurses in the state of Georgia? I say 170,000. Okay, so 170,000, we're gonna split the baby. We're gonna say 150,000. How many people live in the state of Georgia? 11 million plus. How many physicians in the state of Georgia? 15?
27,000.
Okay, let's call it 30,000. We add all of those providers together. Is there still enough to go around for the 11 million souls who should have a right to cost-effective, quality, safe care? It's not enough. And it is incumbent upon us to make sure that we have enough providers, nurses included, everyone. It's not just us. We're talking about nurses here, but it should be anybody who cares about healthcare. Anyone can use this framework and use it effectively. If we would all speak with that one voice that the senator said that there was just no shot of us being able to do, we could elevate the lives and the outcomes of 11 million souls. And guess what, Dr. Hooks and Dr. Collins? I'm not saying can we do it.
We are gonna do it.
We are going to do it. Because one of my favorite deans, she's Dean Emerita now, Linda McCauley out of Emory University, came to a conference one year and said, nurses will save healthcare. So simple. Boom. Nurses will save healthcare. And I know it and I believe it. We've just got to band together and wield our power effectively.
So what I'm hearing, Drs. Hooks and Nelson, is that for us to nursing education to redefine advocacy, we have to move from a patient-centered focus to a systems-level focus, focusing on political competence and workforce sustainability.
Yes.
Dr. Hooks.
Okay, so we're going to move to our next question. So you can probably advance a couple of slides. And I'm going to ask this to Dr. Nelson first.
Okay.
Dr. Nelson, what role should nursing education play in building sustainable advocacy pipelines from students and early career nurses to professional and legislative leadership?
It's the first touch point. We get them first. As those new little green babies in the undergraduate program, they should not come. What happened to me should not happen at all. That I had to get an associate's, bachelor's, master's. PhD, and 16 other things for me to say, wait a minute, what's happening here is not right. We can do. At the time, I was an advanced practice nurse practicing in the state of New York, and I lived in Georgia. I would fly back to my practice. But you know why? I was so disgusted and refused to practice here because practice was so restricted. In New York, I could do pretty much whatever. And I also found that in our green states, those of you who are familiar with the AANP map, what's red is most restricted, yellow is somewhere in between, green is a full practice authority state. When I look at that map, it's the green states that seem to have the best healthcare outcomes. Now, I don't know how to read tea leaves, but only on Saturdays and Sundays. What's today? Not Saturday and Sunday. But I don't think that we need a plethora of longitudinal studies to see the writing on the wall. We live in the Southeast where there's a high concentration of restricted states: Georgia, Alabama, Mississippi, Florida. Some of the worst healthcare outcomes. And these are the restricted states. We must do better. We will do better. And I can tell you that Georgia is going to get full practice authority because Georgians deserve. We shouldn't be getting an A or an A plus for commerce all the time and then an F when it comes to healthcare. We can do better. So this fire that's in my belly, that I'm trying to transfer to your belly, you must go back to your schools and transfer it to your students because their ability to practice teeters on what we are doing today. Someone fought for us. All that we can do is based on someone coming before us and advocating for the right to practice. It may be limited, but it's better than it was. And so their ability to practice to the highest levels of their education, their certification, their training, all of that depends on how we fight for them now. But something I want to go back to something you said, Dr. Collins. Yes, we have to fight for system level outcomes as well and advocacy. But don't you ever forget that you are fighting for the patients first. We're not even fighting for ourselves. We are a byproduct. Our ability to be able to do it is for the patient. So when you're speaking to your students and you're speaking to your legislators, always couch what it is that you're asking for in terms of the constituent or the patient. That's what they care about. Okay, so please, the resource advocacy framework, beautifully written. You did a good job, Dr. Hooks, not Collins. But no matter what framework you use, it is high time that we really make sure that in our educational spaces, that advocacy, policy, and legislation, going down to the Capitol and fighting, and empowering these students to have a voice. This is what we need to do. Okay, it is DEF-CON. What's the highest DEF-CON?
No.
1 or 5, one of them. Whatever the highest one is. If we think that we don't have the military people in here, what's the highest DEF-CON? She said 7. Okay, 1. But it is imperative. And if we don't think that fighting for healthcare is not one of the most important things, look at what's going on in Washington. We don't have to look that far. Okay, we just had a major shutdown based on healthcare. So let's get it together, folks.
I agree with you, Dr. Nelson. So again, what I'm hearing you say is that nursing education is the incubator from all things related to policy. That is a
fabulous word. It's an incubator. This is where it begins, and this is where students must flourish under our watchful eyes and tutelage. Okay, we have to make sure that they have the tools and that they understand that they have the power and the voice. People will listen to us. We just need to speak.
Yeah, and again, I think from a nursing education standpoint, I believe we do a good job in the undergraduate space of teaching individuals how to advocate for patients. We need to take it up a notch so that we're indicating that these are strategies and tools that we should be doing for our profession. And so it's being intentional about communicating what that is, making sure that students understand this is really a professional obligation. We all should know. And if we're thinking more about the legislative space, knowing who our senators are and our representatives, having a communication channel with them, whatever that channel might look like. Is it email? Is it calling their office? Is it using our professional organizations? And so I think, at least in my experience, there seems to have been a decline in our current student population and their interest in getting involved in professional organizations. So I think as educators, we need to alert them to the importance that if you don't have the capacity, you have obligations that don't allow you to be in the political space or the legislative space, you have organizations that can do that and speak for you, but they have to be supported in order to have the resources in order to do that. And so it's making sure that they understand, number one, what is advocacy? And there's obviously the levels that we've talked about. And how do I utilize the concepts that I learned to advocate for a patient and expand those to other topics? So, yeah.
I love your framework. It's excellent. And it's a template that should be shared, if you could, with mass people. I'm listening to everything that you say, and here are my thoughts. We have a ton of nursing programs, even more have opened up in this year. So we're growing in terms of nursing programs and the number of nurses that the state of Georgia will have access to, at least on the day that they graduate. They may leave if they're trying to, if they're in nurse practitioner schools because of our laws. They are leaving. They leave. Yes. So we're hurting ourselves, the state of Georgia, because we have so many areas in Georgia that could use the healthcare providers if we changed our laws. However, the graduates need to have mentors. They cannot learn on their own. So we need to have those of us who are experienced in healthcare and then, our academic faculty and our leadership in the healthcare systems, our administrators. We've got to see that behavior modeled of advocating. It should be discussed in all institutions. Our organizations really should pair up. We're working in silos. There are multiple nursing organizations in the state of Georgia. If we want to move forward and succeed, we've got to work collectively. We've got to meet collectively on these issues. We need to be involved in any of our programs that are offered to educate us more. There should be more than 40 people in that educational session. I'm not talking about this room. I'm speaking of something outside of here.
So I'm going to say, talk about them.
We have to learn first.
Yes.
So that we can know how to advocate. Okay. Then we have to do it and perfect it and be a role model for someone else. And I think maybe we're not teaching the students well because we don't know how to do it ourselves, or we're not doing it enough. And this extends, not only to the nursing practices, but, do we ever advocate for things that happen in our neighborhood, like clean water and that kind of thing? So this goes far, but where do we start in actually getting our leaders together our faculty together to focus on some hardcore advocacy practice.
That's a great reflection. The role modeling piece, I think, is something that we need to expand for those that are comfortable. And there's several of you in the room that are very comfortable because I've seen you there at the Capitol and you understand the process. You bring students, you bring your colleagues. So I think expanding the role modeling behaviors is going to be key, but it's getting the information out. We have discussed, and the issue, quite honestly, has been funding. We, through the Georgia Nursing Leadership Coalition, had discussed, is there a way that we could have a tour of the state where we go to major areas, Augusta, Columbus, Savannah, and have these listening tours so that we can get people engaged in their communities and really begin to expand the grassroots efforts. So teaching people the concepts of what does it mean to advocate. It's not only about things that are specifically nursing related, but you mentioned clean water, access to food deserts. There's a lot of things that from a nursing perspective, we should be advocating for that would improve the health of Georgians. And so it's how do we best communicate, even in things like making sure there's education around policy change, around the advanced practice nurse license, who's the best organization, right, to get that information out to every single person that is going to be impacted. So there's been discussions about that. How do we do that? So I think it's going to be determining how do we create that communication network so we can reach the most nurses about things that impact them. And then how do we activate that resource?
I was having this discussion with someone a few days ago, and I said, why is it that nurses just don't engage? And they said, well, I know why, particularly bedside nurses, they're tired. I mean, it's true. They are tired. They are burnt out, beat up. Who wants to go to a dinner meeting after that? But guess what? I get it, but a little bit of time. If you want to see change, you got to be part of change. You cannot say, I want change, but then you're not showing up to be part of change. It takes all of us. Everybody in this room, I know you've heard your mama say, many hands make light work. It cannot be 5 people, which unfortunately I go down to the Capitol many days. There are days I've been at the Capitol by myself, have gone into the bathroom, cried, and come out and back on those ropes again. No one person or 5 people should have that type of responsibility. Dr. Desiree Clement, wave your hand, let the people see you. She knows it's been me and her at the Capitol by ourselves way too many times. And so I challenge everybody. Everybody is here because you're a part of GAIN. That is a wonderful, great first step. And I'm sure it's not just the first step. I'm sure a lot of you are engaged in a lot of different things. And I want to also give a shout out to GAIN leadership for inviting us to come and have this very meaningful discussion. You guys, if you belong to GAIN, you do, you're here, but there's other organizations that need your help. Georgia Nurses Association, we're having GNA Day at the Capitol, March 11th. Everybody get down to the Capitol and let those people see a show of force. United Advanced Practice Registered Nurses of Georgia is having APRN Day, February 24th. You'll see me at both. I need you guys to come out because we see what numbers in mass can do. You just need to turn your eyes towards New York, 15,000 strong nurses picketing under NYSNA in the cold. I'm proud of my New York nurses, and they're not going to stop. And what are they fighting for? They're fighting for the ability to have consistent nurse-patient ratios, safe staffing. They want to make sure that violence against nurses doesn't continue. They want fair wage increase when they see millionaires and billionaires giving all kind of money, and then our money is stagnated.
Do you have a voice, a story, or expertise that healthcare needs to hear? Voices in Nursing with Dr. Nozil is a professional podcast elevating conversations at the intersection of care, leadership, and health policy. We're inviting chief nursing officers and nurse executives, bedside nurses, and advanced practice registered nurses, nurse educators, and academic leaders, hospital and healthcare system leaders, patients and patient advocates, family members and caregivers, policy leaders, elected officials, and community advocates. If you have expertise, lived experience, or insight that can educate and inspire, there is a seat for you at this table. To become a guest, email Dr. Nozil at ynozil@gahealthcaretraining.com. We look forward to amplifying your voice.